So I'm starting to explain about one of the most important application of infrared imaging, that it's the application to the study of pain, especially the complex pain. It's very important for us to understand that studying pain with infrared imaging uh, can help a lot of people. It can help many people with understanding the application of infrared for chronic pain. I know most of you uh, maybe are not so close with these patients, but if you ask for many people that go to a medical doctor, 90% of them, they go because they have pain. So it's the main cause for someone to ask for help or to start any kind of treatment. Uh, I'm talking here not so much about prevention of disease, but for the people that have are with the diseases and needs to be helped with us with our infrared image. So pain is something that everyone here must pay attention and start to do and have just focus on pain, okay? And pain is responsible for people spend a lot of money with chronic pain. And most of the time, the regular exams, they are, most of them are normal in 18% of them. So when I start with infrared imaging 20 years ago, the main applications were breast cancer and pain. And I decided to start with pain. And during the time, years by years, started the breast. So I first started with pain because
internet connection, but he's
okay.
He's now.
I know.
Here you are.
Okay. Are you see my screen?
Now I can see you and hear you.
Okay. Okay.
Yes, fine.
Excellent. And it's very the pain has the problem because when it becomes more chronic, it's more difficult to find where is the source of pain, because we have central sensibilization. So like this, central sensibilization. What means that? It means that the problem is not more something that is easy to be identified or localized by the patient. And most of these patients, they have diffuse chronic pain, and most of them are diagnosed as a fibromyalgia patient. And most of cases could be fibromyalgia, but there's a lot of patients that don't have fibromyalgia. They have other. And it's very important here, two things. When you don't find a lesion in chronic pain, it's very difficult for the doctors to treat these patients because they don't have something real, or they can see what really happened with this patient. And for these patients, it's complicated because they can't prove that they have something serious. And most of the time, these patients are not considered by not only for the doctors, by the family. So their families sometimes don't believe on their complaints. And the problem of this, we call central sensibilization, okay? Central sensibilization is not a primary diagnosis. It's not a specific diagnosis. It's just a physiopathological problem. And here you can see explanation of Lars R. Nielsen, a researcher, explained that when we have this kind of patient with diffuse pen, you must to asking to him how. So how it started, the problem, how started it, okay? And how is possible that you, with 14 years old or 15 years old, woman with two daughters, how is possible you have this kind of problem? And most they say, I don't know, I have this for a long time. But how it started? It was a trauma. It was something, surgery, or you have lifted, or you have, what happened? So it's very important when we do imaging of this patient that we ask us how it started. Not when. When, okay, when it started, but how. Try to understand the maximum complaint of this patient. And this is very important for us to understand the infrared imaging on this case. The most recommended in this case is to do the full body imaging. Okay, you do the anterior, posterior, superior, inferior image, local, regional. You can do a protocol, for example, 13.2 or 13.8 images or more or a little less. And you must understand that you have a lot of information with infrared imaging and many, many images. And when we explain to a regular radiologist that we do a full body exam, most of them, they look, oh, there's something wrong here. Like, oh, you do a full body, good luck. Good luck, man. Why? Because they know that this patient will have a lot of things for us to identify in infrared image. And we cannot create a problem bigger than it was. What this means? For example, this patient have chronic pain, and imagine that he goes to Linda, and Linda starts to put on the report a lot of things. These and these and these and these and these. A big list of problems. On the knee, on the lumbar, on the shoulder, or allergies, or fatigue. You can identify some aspects, but it's very important that you establish the main find, the main complaint. So when and where started your problem? So if we need to back on the past and try to understand that it started on the back and much more on the left side. So we need to ask for the patient, try to understand this, because this is the main aspect that we put on our thermography report, and where we go to give more emphasis. Okay, so you need to understand that. And after we found this on the image, we'll construct or we'll write a history of what is happening with the patient on that moment. So there's a history, and we are storyers. We are storytelling of what is happening with the patient. So you must understand, not fiction, not fiction, but real. What's happened with me, doctor? Oh, so you need the clinical information to answer that. Because if you put only the problems in a big list, you can create a problem bigger than it was. And when he goes to the treatment with you or with another physicians or practitioner or no mind the specialization, but it must be clear for who will treat the patient, where is the problem. And in pain, chronic pain, there are a lot of changes in the body. There are functional changes and also anatomic changes also on the brain of the patients. And the brain changes a lot. And the thermoregulatory response of these patients also change. So when we have chronic pain, we'll feel pain with less stimuli. So the sound is not good, the light, but when you touch, you can feel much more pain. And why this happened? Because the brain changed functionally and also anatomically. This is a paper where they did their MRI in chronic pain patients with endometriosis, and the researchers saw that these patients have less volume
Excuse me,
on the brain.
Marcos, sorry to interrupt. It seems that the people is having difficulties in order to hear you well. Sorry to interrupt you.
I thought it's not good.
It seems you've got a lot of noise on the background, and also it's very low. So
And now? So it's okay?
No, yes, we can hear you. The problem is that we are hearing the background people, maybe the co-working people.
Okay.
They are talking besides you.
Okay.
You.
I need to. Can you give me 1 minute?
Yes, please.
Okay, just 1 minute.
Because he's in a place where there are some others co-working, or maybe he's going to a closed room, or ask them to talk in another place. It can happen.
maybe meanwhile we can do a round with people in order to get to know each other better and know how came the thermography to us.
Mhm.
How did we discover thermography? How came thermography in our lives? Maybe Linda can begin.
Well, mine is more of kind of a spiritual thing. When my business was closed down due to COVID, I went back to school to continue my education and changed my whole business name to go more towards health and wellness. And yes, I do work with people in pain every day. And I just was praying, Lord, what do I do now? And he just revealed this thermography to me. So I had to go research, and that's how it happened.
Very
Interesting.
interesting, Linda.
Yes.
What about you, Jan?
Jan?
Are you asking me?
Yeah, how did you discover thermography? How came thermography to your life? How did it appear in your life?
My late husband developed lung cancer, and I decided after he passed that I needed to find another way for early diagnostics. I am a nurse, and I was very fortunate that Dr. William Hobbins, who's quite well known in the field, who has now passed, lived quite close to me. So I was able to go study with Dr. Hobbins.
Mm.
Wow, that's an
But I was looking for
thermography.
Oh, a long time ago, I had horses, and two horses both get problems, and the veterinarian don't know what it was. And I was struggling, and I think, why is it not easy to find? And he did not try because he didn't know where to look. And a veterinarian told me about a research with what you can do to see the blood flow. And he said, well, that's thermography, but I don't believe in it. But it is possible, but I don't believe in it. So I figured out, and so I was attending a course from Flair about cameras more for sale. And was also a person a little bit experience in horses. Now I know it's really bad, but he did never record really bad images, but it makes me interested. And I bought a camera. I think I try it, and I took the plane to the US. I've attended
Oh, it seems no. Well, just missing Sidalia and Elizabeth. Maybe you also want to share.
Yeah, I came along to thermography. Well, I remember now. It was a friend. She's an odontologist, and she went to São Paulo for a course about TMD, temporal mandibular disorders. And when she came back to my city, she said, "Oh, Sidalia, I saw something very interesting. Something that it's a camera that can see the dysfunction that capture the infrared waves from the body." I said, "Wow, I can't believe that because I said, oh my gosh, I need to know that." So I met Dr. Birioski in one of those courses, and I was fascinated with the chance of having this camera and understand how does it work. So I did all courses that he had, and then I went to the post-graduation, and I specialized, and I can't just be a doctor nowadays without this camera. I do without the third eye. I do this every day with almost 9% of my patients, because for me was really a big change, because now I have how to document everything, and I know if they are saying the truth or no. And I also can see diseases that the other exams, the anatomical exams, can't show. So it helped a lot to treat these patients, a lot. And I'm enthusiastic about thermography.
Thanks for sharing. Also, Carol told us that she's been performing medical thermography for 15 years. It seems that she can hear us, but she doesn't have a camera. And we've got Dr. Brioski back. Elizabeth, we're missing you.
And now it's okay? Better?
It's okay. Now it's great.
Okay. Sorry. I was not expecting that we have some external sounds here, but I believe now it's okay. Let me share the screen and let's go. I was explained that we have morphological changes on the brain, and also functional changes like altered sensation, altered emotion, altered cognitive processing, and altered pain modulation. So there are a lot of changes and how the brain works. And also the patient will have many different aspects in thermoregulation. So the thermoregulation of a chronic pain patient is totally different from normal one, the normal physiology. So it's totally different for many aspects of that. And at US, it's not so recent statistic, but here it is explained that we have 116 million Americans with chronic pain. So we have a big market for chronic pain, and I'm trying to explain that we have an opportunity to help a lot of patients. So infrared imaging is not just the breast. This is the message I would like to that you know about, and that we can help more efficiently with also focus on chronic pain, because these patients, they have pain and they don't know what they have, and we can help and direct them to the regular treatment or improve the treatment of these patients that most of them are not being in a good treatment. Okay. And the chronic pain, 87% of them are non-specific finds in the regular exams. So maybe they have some disc problem on MRI or degenerative lumbar problem, cervical or knee, but most of these finds, they don't explain the pain of patients. So the main exam actually for the study of pain is not MRI, is not ultrasound, is not X-ray, it's infrared imaging. Because it's the only exam that you can study the pain, understand what is happening on that moment. And MRI, X-ray, ultrasound, as anatomical exams, they only explain what happened, the past, what happened to those patients. It not means that what happened is explain the actual pain of this patient. Most of us will have degenerative problems on the spine, for example, and most of us will have a hernia disc and no pain. Maybe I have one or two, I don't know. I didn't read, but it's very possible that I have at least one protrusion and I don't have pain. And most of the time, it's very difficult for the doctors to correlate a radiological find with pain. So I have many patients with shoulder pain with normal ultrasound. I have patients with abnormal ultrasound, calcification on the tendon, for example, and no pain. So the anatomic exams, they are not good exams. They are not exams for the study of pain, because pain is functional problem most of the time when we have chronic pain. So of all these patients with chronic pain, 13% of them, you find something in most, and these are the cases that could be better, that will be resolved by a surgery, for example. So most of patients don't need surgery and don't have a clear diagnosis. And the problem is the subjectivity. So when we asked about pain, how much you feel your pain? Between 0 and 10. Now it's 8. Okay. If we ask it again in the afternoon or in the evening, no, it's better. Now it's 6. So what's 6 or what's grade 8 or grade 7? It's very subjective, and most of this could be masked by depression. So most of patients can overestimate the pain. Other doctors could don't believe on the patients. And there's other problem is the secondary gain. What's the mean secondary gains? The benefit that these patients has with the government, and most of them, they need that, but they can't prove that they have this problem. And when they show the regular normal exams, they can prove that they have rights for benefits from the government, for example. And we have people that really need that, most of them, but most of the time, the doctors don't know if they are really have that, or if they have a secondary gain they want to do on this position. And infrared imaging is a way to prove that is something wrong with them. But it must be related with the clinical history and the physical exams. Here is a patient with complex pain, and it's not possible to see where is the problem. It's in the right or the left hand. But when we do infrared imaging, we can find the source of inflammation. It's the base of infrared is to find the source of inflammation. We cannot do we cannot looking for something that we don't know what we're looking for. So you must to ask before to do the exams, where's the local of your worst pain, the maximum pain, or what happened with you most of time, where on their body. It's all the body, but where? It's upper body, but where? It's both shoulders, but where? Both, no. Again, the right or the left? Most of the time the right, so the right. You must to classify before you do the exam, okay? And we have diagrams of pain, and we put this mark, and we're looking for them. And we need to do infrared imaging as the same way as the other exams. We need to do the same way. We need to have a methodology. The exam must be possible to repeat in the same conditions when you are doing reports. So we have a protocol to do ultrasound, MRI. So we must follow a protocol to do infrared image when we are offering reports, okay? But when we are in emergency room or in basic consultation, and the focus is not the report, you can have some adaptations of the protocol that we call point of care. Point of care, it means that you can do, knowing that it's not the best protocol, but it's possible to find many things and to do some treatments and to follow the patient, or to understand what the patient needs on that moment. So we call this point of care. Point of care, that means that you bring your camera very close to the patient. So in most of time, the cameras that you're using, these cameras don't have lens for close pictures. Most of the time, these cameras do a focus in 1 meter, 1.5 meters. And here I'm talking to do images 13 centimeters of distance, so close as possible. We can touch, so close as we can have the camera in one hand and the other hand trying to touch the patient, what is happening. So we call that clinical infrared guided exam, infrared guide. So let's divide here. We have here something conventional, the best practice, okay, the conventional thermography, but we also have the option when we don't need a regular report, a point of care, okay? I'm trying to explain this. And I believe most of people that doing conventional also can do or have the opportunity to do point of care. I'm not saying that they need to change or to choose which is the best, because this is not the point. You must understand there are different aspects or different ways to approach with the patient, okay? And it's very good that we are open the opportunity for point of care approach, because we are seeing many doctors more interested on this technology. Because when you send a patient to do a full body exam, and when you expect a report from them, you must understand that you lose a lot of time. Maybe 3 days, but most of the time 7 days. The patient needs to go to another place, do full body exam, and after you send the imaging, you have a report and you send it back. So it's okay. It's good to have the aspect of the conventional thermography, but we have the opportunity actually to do the images during the consultation. And many pain doctors that work with pain medicine and neurology, they are doing the infrared imaging during the consultation, touching the patient, doing the clinical exam, and understanding some aspects of this problem. Again, I'm not saying about breast, I'm talking about pain now, okay? So what they want to know, they want to know if it's really, if the patient really have pain, if the patient really
Marcus,
have pain.
Excuse
Okay.
me, sorry to interrupt you again. People asking you to speak louder.
Mm-hmm. No problem. And now it's okay? Better?
Much better.
Okay. Okay. So here's the guidelines for neuromuscular skeletal infrared thermography sympathetic skin response. It is published on the PAGMT, the Pan American Journal of Medical Thermology. It was a work where I believe Jen, you take part of this guideline. I believe you heard Dr. Schwartz was the main to develop this, and also I had some contribution too. And this guideline is you find on the Pan American Journal of Medical Thermology. It's a free journal. You can have a free access of these protocols. And I believe, Belén, if you find that, you can share for us on the group. And so this is for the conventional approach of infrared imaging. And here, you can see in real time, I just showing the full body on that moment. And sure, we ask the patient to stop, and we take the pictures and ask the patient to move, etc. But when we do the point of care in movement like that, it's possible to analyze is the same as we have a lot of images on that moment. For example, if you have some complaints here on the abdomen, and you're doing a movement of the patient, you can see in real time much more information about that problem, and it be more clear for you to understand what has happened compared with only a front image or with a lateral image. So you have a lateral, anterior, but when you have the movement like that in real time, and this is very common when we are doing the point of care, is the same as you have a lot of information and you can understand better what is happening. So it's a vascular problem or like a vascular shape, or you can relate better with the history of patient, if a liver problem or it's a trauma with a myofascial problem. So I'm trying to incentivize all of you to think doing the images in real time like that. Okay, you can do far from the patient, you can do close to the patient, you can do don't need to be totally naked as here. So here, this patient is very well prepared for the conventional full body exam. In the beginning, when I started to do that, I didn't start doing full body like that. I started doing only the upper body and the lower body. But I observed that many patients, most of patients have problems on the upper and lower body. So many years ago, I changed the way. So actually I don't do upper or lower. I do full body. So I understand that when you have the full body, you have the full information, especially in the musculoskeletal aspect. Because most of the problems, musculoskeletal problems, are related with posture, myofascial chains, and if you don't see all the image of the full body, you can understand the mechanical overload of that. And this is very important because most of the overloads are perpetuating factors of chronic pain. And when you document this and pass this for a chiropractor or a physiotherapist or someone that will give physical rehabilitation, and when you map this for them, is very good because it's information that we will not find on X-ray, MRI. So the only exam that explain the overload and the myofascial problems by imaging is infrared, okay, thermography. And another thing I changed many years ago is about to be naked, full naked, or a little naked, or just some parts. And I understood that if the patient is going to do an exam for a serious problem, as chronic pain, and when we are there, prepared to helping them, it's better that he don't hide nothing from the body, so expose totally. Most of these patients, they do the exam naked. That's my recommendation. But there's a nurse or assistant during the exam. I did many times the exam, but I'm doing the images with assistant with me. But it's very important we have assistants here and that patients feel comfortable to do the exam. And how they become comfortable if they are naked. Do you know how? An idea? Because I thought that in the US it'd be a big problem, but recently I have a good experience. I was there 1 month ago. I did some exams, and all the patients that I helped, the doctors there, they did the exam naked, and they feel they prefer to show the problem, because the point here is not prevention of something that could happen. No, we're talking with someone that is suffering pain, and if the pain is on the hip, especially on the hip or in this area, they must. And so it's very important that who is doing the image must be someone very confident with this patient. So you need to talk with this patient before to do the exam. It's not just doing the picture, but understand how, where, when starts his pain. Okay, so we must understand this. And this anamnesis, this clinical history, is something with 10 minutes, 50 minutes. So the conventional protocol says that we need to wait 50 minutes. So it's not for you to leave the patient alone at the room, waiting 15 minutes, doing nothing. So I ask to the patients, take off the clothes, put, I don't know how to say that. Como é que fala?
It's a surgical dress.
Yes, a
That
very soft, because when the
soft
patient,
one.
huh?
It's a very soft surgical dress. That dress we put in the patient going.
A cone or a rope.
A pro.
Yeah, apron, yeah.
And the patient take off all the clothes. He needs to do that. Out. And put the apron and wait 10, 15 minutes. But on this moment, we will do the questionnaire again. Where, when, how. They must show picture on the diagram of pain. And when we start, we put the patient stand up in front of the camera, but he must to look of his image on a monitor. It's very important. So if the patient don't look for the monitor, if you don't see his body on the monitor, sure, most of them will be very embarrassed with that. But if you put the monitor on the right side in the wall or the left side, and he can see the image of his body, he understands that we are not looking for his regular body. We are looking for the infrared imaging. We are looking for the biology, the problem. So on that moment, it's very good that you give a pen to this patient or something to a pointer, and ask him, point me where you feel your worst pain. So it's very interesting that he showed. And you must to adjust the camera, the lower and the upper temperature. And the patient must understand where his point, the pain, there's something wrong there. So it's very important that you explain what you're doing in that moment. Sure, you explain it's innocuous, no radiation, no touch, but you must show a basic find. The basic find is what you're saying is really true, because it's possible to see something most of the time, a hot spot where his point. And it's very good because it's very impressive to the patient to understand, wow, I have a hot spot in the pain. So in that moment, the patient will understand that you found something that nobody found. What it could be a myofascial, could be arthritis, could be neuropathy, could be no mind. You must just say, here, we found what you have. We found something wrong here. Let's do all the image. Let's go ahead with to the end of the exam. And after this, I can give you a report, etc., etc. But the first image, you must to prove the patient that you're showing something wrong to them. So points, oh, there's something wrong. Yeah, oh, because in the mind of patient is a diagnosis that you did something that helped him. Okay, but sure, we need to translate that, to put name of that, to explain what this means. But for the patient, he'll be more relaxed, and he'll be very cooperative to go on with the exam. So I did this experience at US, and sure, at Netherlands and Brazil, Argentina, Uruguay, Chile, other place. And no, it's the same. People if you do that, it will works. But if you feel that patient is not feeling good or is embarrassed, it means that you did a good approach before that. You didn't were so welcome with him. You need to open to listen him. Okay. Sure, we respect you if you don't want to take all the clothes. I understand. No problem. Stand up. We show the problem. And after that, I say, oh, now you believe me. Now you understand. Oh, yes, please. If you take off your underwear now, you can understand better the problem on the hip, for example. And most of patients will accept that and understand that we are not doing a photographic study. We are doing a medical exam, totally different. Okay, we want to help this patient. Okay, I would like to open for question now. Any question until now? Because we are in a very sensitive point here. Linda, do you do the exam with naked patient, totally naked? Or you didn't never that?
I've done both ways, depending on what the client is comfortable with. Yes.
Okay. Is when you do the exam, you show the image to the patient during the exam?
I have it where they can see the image.
Mm-hmm. You show the image on a computer or on a big monitor?
Well, I have a big monitor in my room, but normally I use the computer because that screen is so big. But you just gave me the idea to put it on the monitor.
Yes, it's very easy to put a cable between the computer and a monitor. And it's possible to have 2 or 3 monitors at the same time, because in a big screen, it's very important. And big screen, sure, the size exactly depends of your clinic, but it's very important to show to them, because when you show and when they understand that you're seeing the problem, you make something very important. Connection.
Exactly.
Okay.
Yeah.
If you don't say nothing during all the exam, no, I'm not saying nothing. Everybody quiet. Oh, it's stressful for patients. So they become, oh, when this will finish. But when you're talking with him during the exam, it's much better. You make more connection. Okay. This is why point of care is increasing the interest of many doctors. I understand, but as I told you, you must do for reports, you must follow the conventional methods. But actually, you have the opportunity to do only the image of a lumbar or the knee, have idea what's happened, and make a treatment if you do a treatment on that place. Okay. Who's here more? Linda. And you, Linda. Linda, no, sorry. Again, I don't know. Julie is here. Yes.
Carol was sharing in the chat group, and she said, I think her audio is not available. So
Carol
she
is
said,
not
I see
available.
the privacy screen, so the patient cannot see me. This is what Carol said. I sit behind a privacy screen so that the patient cannot see me.
Yeah, I don't recommend that, because you increasing the stress of the exam. And the idea here is why you do that? Why you do that? Do you think it's better to be not to be present during the you're losing the opportunity to give much more for the patient. You lose the opportunity to make connection. You losing the opportunity that if we return to talk with you and repeat the exam. I sometimes I can understand, for example, for breast. No, it's just for breast. Okay, finish. But full body in a chronic pain is something. Oh, more details. And on that moment, it's possible, for example, you can find many things different that patient didn't listen, talking to you. For example, it's possible to find, oh, there's something wrong here on the right knee. There's a lot it's bright in the right knee, or is a hot spot in. We don't have any problem in the right knee. Oh, Julie, I remember now. Yes. Wow. It's good that you asked me, because I had to understand it. During the exam, you can find other things that's very clear, and you need to write that on the paper. You write. So we have a protocol, front, back, up, blah, blah, blah. But we need to focus. We must to understand the main problem. The main problem appeared something. Yes. Okay, great. Which more I can find during the exam? And if you found something in the knee or varices, you ask, complement the history of patient, confirm if he has any pain. Oh, I don't have pain here. Is any problem? Oh, no, I just taking note here. No pain. Okay, no problem. I just understand. And you use the same diagram of pain and complement with your comments during the exam. So we have the diagram of pain before the exam, and during the exam we complement that. And also you can use different colors if one. So the patient is a blue pencil, paint that, and you use a red one, and we understand that this is something from the patient, and this is the comment of you. And when you do that, the report will become much more clear. The report will be much more related with the problem of patient. Because the main problem most of the time I saw on the reports is that people put a lot of things that is not really important for the patient on that moment. Okay, we have many problems on the body. Nobody is perfect, so much older, more problems, more surgery, etc. But we must to divide what's the problems really related with the patient, what they're really feeling now, and separate the secondary finds. Secondary finds. Maybe he can have this and that and a problem that, but it's secondary. But what being secondary? No pain, no complaint. We must just separate, divide this on the report. Okay? Because if the patient read all the things there, confused. If you start the report saying, for example, the patient have a shoulder pain, and the report starting saying the musculoskeletal problem is possibly a tendinitis on the right shoulder, blah, blah. Okay, the aim of the exam is okay. You found the problem is an inflammatory problem in the shoulder pain, and secondary finds. Oh, there's a problem on the back, on the calf, the left calf, and the hand, blah, blah, but are secondary. You don't give so much. You need to separate and not put on the same level. Are different levels. Okay, it not means that it's not important. Secondary findings, they are important, especially to prevent problems on the future. But we must take care not to mix these things, because for most of doctors that do the treatment or rehabilitation, they need to focus on the main problem. They need to help. For example, if I have a lot of pain on my shoulder, I'm more interested to solve the problem in the shoulder, not solve the problem on my intestine and the bowel and so on. Okay, you have a problem in the bowel, but my complaint is shoulder and is an inflammatory problem in the shoulder. So the focus is in the shoulder. Next month or early, I treated the bowel also, but it's not said you need to separate that. You want to comment that, Sidalia? What do you think so?
Yes, I would like to say, sorry. Yes, Dr. Biroski, I also remember that something that we do to make the patient more confident and more relaxed, we use a TV, and this patient can follow the exam, watching their own infrared imaging in real time. So it makes them more relaxed. They know what we are seeing, we are not taking picture of their body, but the emission of the infrared. We explain them before the exam. And when they follow his own infrared imaging in real time, he sometimes say, oh, is this red spot there my pain? Because it's the lock of my pain. So I think that's a very important point to put here.
Please, Jen, you want to comment? No problem. I want to say that we don't have the perfect protocol yet, and we can have variations on that. There's no problem. But it's interesting that we change the experience between us and try to bring to our practice what is better for us on that moment, or in my culture, or my city, on my clinic. So the idea here is not to say, oh, it's forbidden that, it's approved that. No, you must balance this and try to find something that is better and that you improve. So this is the idea, okay? Go ahead, Jen, no problem. Would you like to talk with Jen? No? Comment?
No, I just wanted to say that in a technician's office, then you're creating a situation where the other practitioners who don't believe in your study can say that you're practicing medicine without a license. So you have to be very careful with that.
With what?
Doing what would be a point of care exam, which normally would be a physician in the room doing it. A
Yes.
technician doing that type of exam is presuming a diagnosis or indicating,
Yes.
that this needs to be treated.
Yes, is very important that. So here we have a point that we must take very careful here, because point of care, it means that you're giving a preliminary diagnosis of this patient. You don't need to be the definitive diagnosis, but you're doing diagnosis. And when you say here we have inflammation, or here we have a trauma or a vascular take care. So point of care, really, we must be understand that you're doing a diagnosis on that. And if you are a technician, maybe you must take care of that. It's not permitted on most of countries, also here in Brazil or in US. It could be a problem. So, but if you're doing a report, okay, but you understand that someone will give you a report, but you can't say that something wrong when you're doing the convention. Oh, maybe just for education, not for give a real diagnosis. So when patients say, I have something here, the clinician can say, oh, okay, oh, maybe, yes, it's very different. Let's take all the picture, as I will inform, I conduct you to the end. Yes, but let's see, the doctors will give the final diagnosis, the final report, but it looks like something strange here, strange. I don't know. I'm not sure, but look like, because most of the time and there's something wrong there. But you can, as a technician, you must take care not to say what is that? Is inflammation or a vascular problem? So yes, there's something wrong here. Let's see.
All I tell them is they have an asymmetry.
Yes,
they have an asymmetry, and that it has to be correlated with the clinical problem.
We review the image, because the image here is just aspect we can study better. Maybe yes, maybe no. So you must incentivize the patient as all, but you can't say not to assure that's really there's a problem there. Okay, but only for the main problem, just for the main problem. Other things you put notes. You can ask. I think a technician could ask if they find something wrong on the knee, as I explained before. You can complement with more questions. Oh, do you have any problem here on the knee or trauma? Is there something? Just to confirm, is okay. Oh, yes, I have. Okay, I put here. The doctor will have this information. So you can complement the questionnaire with some finds, but you don't say it's a big problem. The problem is here. okay? But unless if you the doctor that will really treat that patient, that is different, okay? And other things interesting as we have different kinds of diagnose and different kinds of reports. What this means? This means that, for example, I I can do a full body exam, have a lot of image, full body protocol, but if I'm preparing my report to a neurologist, for example, or a neurologist that asks me, I will write with his neurological language. I will give more emphasis on the neurological finds because he is expecting me the neurological. I will give all the information, but I give more information on that. When it's not a doctor, for example, a chiropractor or a physiotherapist, or I give more importance, or give more information about the musculoskeletal, the posture, the imbalance on posture. So I need to understand when I do a report, okay? I need to understand who will read that. So the reports are not the same all the times. Depends of who is asking and what he wants to expect it from the exam. Because if I do for all the situation the same exam, most of the doctors say, oh, it's not a problem for me. I don't want to know about posture. I don't know. So he must to know, but but we know that most of that don't like to have understanding of all the problem of the patient. But sure, I put all the problems, but I change it or I emphasize different the main complaint, and I try to because the exam is for whom? The exam is not for the patient. So the exam is for someone that will treat the patient. So if a patient comes with me and say, I want a report, okay, but who treat you? No, I just want to do thermography. No, there's someone need to see, to treat, to monitor, and no mind if it's normal breast or a normal exam, someone needs to follow up, okay? So the exam is not for the patient. And we must to take care when we sell infrared imaging, because we must to sell for someone who treat. If you treat the patient, okay, you're doing for yourself, the exams because you're doing the treatment, okay? But if you're doing for other people, you must understand that your client is not the patient, is the who is asking the exam for you. It's totally different.
Dr. Briowski, I think Linda wants to say something.
Yes, I'm happy.
Yes, I wanted to comment also on what Jan said, that yes, I'm a thermographer, but I'm also a medical massage therapist, and I have so many roles. So what I have to do, what I always do when I'm imaging, is when the client begins to ask questions, that I do the same disclaimer I would in my other fields and let them know that I cannot diagnose. However, I have a lot of clients I work with pain, and I know the skeletal and musculoskeletal system so much, and I work with them. I see while I'm doing their imaging to send off what we need to be working on in the clinic. So it helps me be able to use that better, to have that information, as well as, when you see the signs of lymphatic congestion, so to speak. And so it helps you know what you can do to help that client. But we always have a physician read those. So we do have to make that very clear. And because I have so many different licenses, I have to be very careful. So we do have to do that. And clients always want you to give them a feedback. So you kind of have to say, we need to wait for that report from the physician.
Do you feel comfortable what you're doing actually, or do you have some examples of when you do not feel comfortable? If you want to share with us your experience with uncomfortable case, do you have uncomfortable situations?
You
can help
mean when
them.
I'm looking for myself to see what I see on the
Mhm.
imaging? Is that what you're asking?
If you have situations that you don't feel comfortable uh, to treat the patients, or you find some more than expected,
Sometimes there's things that
or
I know. I believe in referring out, and I have a whole list of people and physicians and other people that I will refer out to because I can't do everything and don't want to do everything.
right? No, but there's
But
nobody here,
I believe
nobody.
we need
Yeah,
to, yes, we need to have a network of people that we can refer
yes,
out to. So I believe in doing that. And
yes.
when there's something I know that I can't do or that I feel someone else could maybe help them better, I will refer out. So yes.
Great, great. Because we
Mhm.
must to have friends and
Yes.
other contacts to reference, and but we must to talk with them what we're doing. Or we are
Mhm.
doing infrared. Maybe can I send you
Mhm.
if I find some vascular problems or musculoskeletal
Yes.
problems or neural problems?
Mhm.
I can send for you
Yes.
to confirm if it's okay or to merge or to give a
Yes.
feedback for the patient.
Mhm.
Okay.
I have had a situation this past year when I was imaging someone for their breast, but I happened to catch something that I knew I needed the image. And so I said, look, can I add this to your imaging? It had to do with dental and stuff. And I was like, I'm seeing something I just want to get a look at. And she said, I had a panoramic view last month and I'm sure everything's fine. I said, well, how about if I do this and we don't charge you extra because I want us to see? So we sent that to be read, and it came back that there were some issues that she needed to follow up with her dentist. And because she had the panoramic the month before, she did not follow up. So 3 months later, eating something that was not even hard, her tooth just fell apart. She goes to the dentist the next day and they send her to a specialist, and she had necrosis in her bone in her teeth because
Oh,
of a medication called Fosamax.
uh-huh.
And they were able to work on that. And then later she had all that work done and then spoke with the specialist and they said, well, if you would have come when you found that out, you would not have had to go with this because she went really a total of like 6 months almost before she had it completely corrected. So,
But the
sometimes I see things and I don't know what it is, but I know it's not good. So
Mhm.
I will
No,
send it.
and
Yes.
you don't need to alarm the patient. You
Yes.
must just say, "Oh, it's better to you just see that." I don't know, maybe it's nothing, sure, but
Mhm.
I can not sure about, but maybe it's not okay. Return here,
Yes.
and also for breast, most of time, because for example, I have many situations that patient have a lumbar pain or knee pain, but is there the breast is image is there on the full body exam. The patient is not think about that. They don't want to know about it. So it's not the focus of that, but there's something wrong on the image. And I just say, oh, it's asymmetrical, not looks normal. Return for with your gynecology just to review. Someone need to review to uh, touch the patient or examine that. And if it's not nothing serious or no problem, can return. You can. I will follow. For example, I will treat you your lumbar pain and I can repeat the exam in the future and we can review that. But the responsibility now is with the gynecologist. So gynecologist can say, oh, I want to follow this image and I want that you return with Linda every 6 months or in the next year. I want you do a ultrasound or mammography and we can, okay. And you, Linda, you can say, okay, I can do, and you have another physician that is in your list of person that you can send your patient, and just that. Because we are in a clinical approach, we're doing clinical approach. We are not possible to do biopsy guided with infrared, and we cannot uh, have 100% say, oh, it's really cancer, except if you saw something in that. But we don't need to high responsibility with that. We just need to inform and to try make the things become more early. So if it's something really serious, okay, it must be confirmed on traditional approach, doing ultrasound and make biopsy, etc. But if you was the first one to say, oh, there's something wrong here, great, you did your job. You don't need to say to answer, oh, is cancer or is not cancer? Mm, so you need to follow up, okay? So the responsibility need to go to another physicians and you can help. Carol, you want to talk? Okay, go ahead.
Yeah, I will be the voice for Carol because it seems she's having problems with the sound. So she sent me a direct message because she wanted to share that she talks to the patients before pulling the screen around, and she also let them watch on a large monitor. And she says, I find the privacy screen especially useful when imaging men.
Let me see.
When I image men for pain problems, I make them bring a spouse. I don't image a man when it's just the two of us in the office. You can have a lot of liability.
Let me see.
Yes, it's fine. It's very fine, Jam. She asked someone to be with them, a spouse. Okay, it means a valet, a friend, someone that it will be with them. All right. I do the same. Sometimes there's a family when the husband come, the wife sometime comes together. So
okay, let's go ahead. I'm share here. Screen again. It's okay. Discussion. Can we go ahead? Okay. Let's go. Let me change it here. So we must to understand that the image is that we are doing is a superficial image. It's from the skin. It's the skin that we are studying.
louder.
And the skin, you have arterial. You have this triad here: artery, vein, and sympathetic nerve. When you have obstruction of artery, you have a cold image related to skin. When we have obstruction of the vein, you have a stasis, or the classic example is varices, and you have a warmth of the skin. And when you have a lesion of the nerve, you cut the nerve, or you do a blockage, anesthetic blockage, for example, you increase temperature also. We call this sympathectomy. Or when you have a compression of this nerve, there's the skin become more cold because you have a irritation or compression of the nerve. So most of time, the main to understand what is happening with the patient is to understand this triad here: artery, nerve, and vein. But you must to understand that if you have an increase in temperature or decrease, there is something that is open the artery or close the artery. And what is this? Is the sympathetic nerve. Most of images and problems, there are some sympathetic relation. So if you have also inflammation on the abdomen, or abdominal pain, or a very deep problem on the joint or on side of your body, the image will be related with the sympathetic response, okay? And when someone asks you how deep is possible to see if with infrared, you must take care how to answer this question. for example. We know as thermologists and the image is superficial, is only the skin surface. Okay, but it's not explained well our exam, because thermography, sure, it can analyze deep structures, can analyze deep problems doing surface image. So how deep is possible to see with infrared? So they don't, when someone asks that, they don't want to, he's not asking about the physics. You want to know the indication. So you must understand to explain, no, so deep as a myofascial or visceral problem. But the image, sure, is in the surface. But how is possible? So deep muscle give a surface change on the skin. It's possible because you have a sympathetic response, especially on pain. Everything, any situation when you have pain is related with there's a reaction. So if you feel, you have a reaction. And this reaction is decrease or increase of sympathetic response. Most of the case, we have both situations, colder or hot, could be colder or hot. On the source of pain, for example, when you have a median nerves compression, a syndrome tunnel-carpal, most of time, the place where you have a compression is hot. Also, when you have a radicular pain, you see on the back, paravertebral, increase in temperature. So this is the source of pain. Most of the time is warmer. It's warmer, and you have a sympathetic inhibition on that place of entrampment. If we have entrampment, it's warmer. And it's not only the inflammation response or the typical inflammation, because we call that neurogenic inflammation. And what means neurogenic inflammation? Is inflammation that is chronic, low grade. It's low grade because most of the time when you touch, you don't feel that. So this is why we use infrared to see that. And it's a low-grade inflammation on that place, and it's a neurogenic. It means that the nerves there, the end terminals, are sensitized, are sensitive, very sensitive. I explained on the beginning the central sensitization. Okay, central sensitization, it means that, it's the brain involved. But the first step before the central is the peripheral sensitization. Because it's possible someone have a shoulder problem 4 years, 5 years of pain, or a tendinitis, 5 years inflammation on the tendinitis. How is possible? It's possible not by the conventional inflammatory process, the physiological inflammation. Physiological inflammation is something that lasts 4 weeks, 5 weeks, but when it becomes, and when it's not a return to the normal, it means that you have a terminal sensitization. And this is called neurogenic inflammation, okay? So the neurogenic inflammation will be very easy to find on the infrared image. It will be sure on the surface, but it will be related of something most of the time deep. Could be 5 centimeters deep, could be 8 centimeters deep. No minds, because this inflammation gives there's some nerves there that goes through the medulla, to the spine, and the spine sends the response on the skin on the same place of the problem. So the skin becomes more warm, not visible, not possible to feel, but it's possible to see on the infrared image and measuring what is happening with the patient. Go ahead, Sidali. You want to talk? No?
Yes, I just said that it's all about the dysfunction of the sympathetic nervous system, neurovegetative, né? That regulates the body temperature. So a patient with dysfunction of the system will represent asymmetries to the interpreted to be interpreted together with the patient's clinical history. So when you take the thermogram of this patient, you can have this this asymmetry. Sometimes in the patient said, "Oh, I feel pain in this hand." No other exam can show, but if this pain it's due to a central sensitization or peripheral sensitization, you see that there will be asymmetry, the temperature asymmetry. So you can recognize when you take a picture, you make the imaging of this patient with the thermography.
And
it's a reflex response.
Yes. So if we have a compression here on the nerve, we have increase of blood flow in the same place of compression, okay? No matter how deep is that. It's superficial or it's more deeper, and the skin will be warmer and there will be a vasodilatation. But the nerve, the innervation is not finished here. It goes, for example, could be a compression on the plexus.
Yes.
And the patient will feel the pain on all the arm. And the continuation of that you have a decrease of temperature of most of time. So when you have a radicular problem, there's increase in the vascular vasodilatation near the compression, near the end disc compression, but all the leg or all the arm will become more colder on the dermatome or thermatome. Thermatome, it means the name is specific for when you have a decrease of temperature in the same area of the innervation of that nerve, specific nerve. 5S1 become more cold, okay? So when I see in the image far from the patient, possible to see, oh, we have a cold leg here or a cold arm on the right. Most of time is the place where the patient have more complaint, but you need to looking near the vertebra to see if you find the warm area. So this is the source of pain, the origin of pain. Where's the compression, okay? So it's very important to do close image and far image. What is a hot spot? What is really a hot spot? The hot spots could be many things, but most of the time is the vasodilatation of a main branch, also artery and vein. And we call these vessels that goes perpendicular to the skin, we call them perforators vessel. Why they are perforated? Because most of the time they perforate the fascia. So it's a vessel that cross the muscle, cross the fascia of the muscle, and cross the fat, and goes here to give nutrition to the skin, and it's open. So when it opens, there's a hot spot on that area. You can have one hot spot or many hot spots or a big hot spot. So hot spot, it means you open the vasodilatory effect. So there's some kind of inflammation or neurogenic inflammation. You open that, and you increase in the temperature of that. Here, I use in a cold object, and I'm cooling the skin At the same time, I'm doing a compression for some seconds. Here's just an illustration. And see, I take off and there's a point here. What does mean this point? This point means exactly this, the perpendicular perforator vessels. So what is a hotspot? It's a hotspot like that here. It means that you there's something that is open the flux, the blood circulation, something pathologic, something wrong, the nerve, the skin. Because and it's possible to see is as a hotspot. Okay, so the temperature of the room is more cold. There are no vasodilatation here, but here you can see that a vessel perforator on this image. So the image most of the time are the effect of vasodilatation of these vessels, superficial vessels. And these vessels are most of the time located not on the epidermis, but on the dermis, 1 or 4 millimeters deep here. So, and here is the skin, is the mirror, what is happening inside the body. So everything that is happening inside that's wrong, the skin is like a mirror of the problem inside the body. And this is a neurological reflex. It means that the thermography exam most of the time is a neurologic exam for most of the things, not only specific for neurological problems, but when we have infections or inflammation or fracture, or you have a neurovascular reaction, neurovascular reflex. And when we put the patient on a cold room or in between 21 or 22, 23 degrees, these vessels will respond with contraction, decrease in temperature, except if you have a problem on the sympathetic nerves. So if you have a sympathetic inflammation or inflammatory neurogenic pain, the vessels will be vasodilated and you not have decrease of temperature on that, and we call that hotspots. Okay? Oi.
Can we say that the hotspot is something more local? For example, if you have a musculoskeletal or myofascial problem, myofascial pain, and you have the trigger points, you have the hotspot. So usually hotspot, we think something more local, different from a hand, a cold hand, and a hot hand, that we can have this asymmetry because we think more systemic, and a systemic reflex response. But we can also have this peripheral reflex response. That's what Dr. Brioski is saying. So it makes the difference.
And it's very important during the point of care, for example, that we localize it where is the most hotspot, where's the most warmer hotspot. Because most of the time it's possible to see many of them, but which of them is the most hot? Because the most hot of them that is asymmetrical, especially, could be or not, but most of the time they are symmetrical, there are different aspects, and they are very hot, is more sensitive. So we are on our practice of pain, during the point of care, we ask for the patient, point me where you feel more pain. Here. And with your finger, like a needle, we compress the hot spot and have the pain reaction of patient, jump sign. So, oh, it's here. How do you know? I'm seeing it's there. But it looks like simple, but most of doctors don't have the capacity to do this during the the clinical exam. Why? Most of the time we put the hands looking for the problem. It's here, it's here. Where you feel pain is more here, is more here. When you're seeing the image, when you're seeing the hot spot, you go direct on the problems. Wow, it's one chance. Like in the first time you be right, but you don't need to do this movement of the hands, but you go direct on the main problem. But we only do that at the end of the exam, not on the beginning, just at the end. So most of the time you take a pencil, mark that, or mark the main, the secondary points. And at the end, it's possible to confirm. And with our touch, it's possible to understand it's more superficial, more deep, or more related with the joints or a tendon, something like that. It's very interesting. It's very helpful. There are a lot of treatments for that, local treatments, ultrasound, shock wave, laser, needling, acupuncture, blah, 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 blah. A lot of many options. Sure, depends who is doing, will give his best to give that treatment. But most of the therapists, they don't see where's the main or the source of pain. So mapping that is very important. We have some situations, for example, doctors that only do needling. So they don't need a full report with a lot of things. They just want, for example, I want that you map me the back of that patient. I want that you mark or take some pictures and say me where's the main source of pain. It's a technique, okay, but it's not everybody that use that technique. But there's some group of doctors that they need this information and to start the treatment or to start some kind of push. Okay,
Right.
okay.
Okay, especially if you are going to treat the patient.
Yes. But when we are doing the full report for the full body exam, the full report, so depends of the complaint of patient. If the patient have a complaint and you find the hot spot in the muscular areas, sure, it look like or could more probably be a myofascial pain or a trigger point related with that hotspot. If the hotspot is near to a joint, most of the time it's not muscle, it's a tendonitis or a bursitis. So a hotspot not means trigger point or not means a tendonitis. Could be in both situations. It means inflammatory neurogenic pain or neurogenic inflammation. This is what means neurogenic inflammation. Someone needs to touch, to feel, to repeat the exam, to evaluate that, okay? But if it's located with near to the muscle, oh, it's probably a trigger point. If it's near in the joint, probably a joint problem. This is the base of a hotspot. Most of the time, in myofascial problems, it's very common to have a lot of hotspots. But it's important that you mark or to identify the main hotspot, because the main hotspot is the one that you must to release or to solve, because the main hotspot is the hotspot that perpetuates the pain. Okay, so if the therapists don't find that or don't understand that there's a main and not treat that correctly, it's very frequent you have a recurrence. And it's also important to understand if it's only a hotspot isolated or on that region, or if there's associated with a cold arm or a cold leg, because if you have a cold extremity, the chance to be a radicular problem is very high. is very high. So the treatment change a lot when we find that. The treatment is not more only the trigger point, it must be the nerve release or the nerve release near on the spine. Okay, let's go. Here.
Oh, Jan is having a question for you. Maybe
yes,
you
thank
can.
you. Go ahead.
Jan, would you like to share directly while with it?
I didn't understand.
A lot of times we'll see a dermatome or a thermatome, that follows
Yes.
from, like if they have a complaint of something, I look at the full region from the cervical or the full region from the lumbar, because that indicates kind of the pathway of the track.
And
like on your pictures that you have here for trigger points or the myotomes, how do you differentiate if that neck is related just to that cervical spine, or is that from the lung?
So repeat the question.
Because the lung will refer to the neck.
I think that's what he's going to show now, Jem. The cervical and the lumbar roots. I think he's going to talk about this dermatome, sclerotum, myotum, angiotum, and vasotome. I think you have your answer done with this explanation now. I understood what you.
So when you have a neck pain or a back pain, you must to do for the neck pain, you must to do the hands image. You must take a patient on the hands image, dorsal or the palmar. And when you do a back image or as a back problem, you must to do the feet, the foot dorsal or the plantar, because if you find a complete aspect of asymmetry, you understand that it's really a radicular problem and it's not a hemispheric problem. So radicular problems like C6, it involves the thumb. So if the patient have neck pain and there's a difference on the thumb complete until the last phalange, until here, the nail complete, you have a radicular problem. And most of the time we find this in early stages without reflex problem, without the strap, or they don't lose the strap. So C6 is on the thumb, C7 on the third finger, and C8 on the fifth phalange. When you don't have complete image or some more less or with low, not so high temperature difference, but more specific on the shoulder or just on the scapula, is not the radicular common aspect, is the sclerotum aspect. What means sclerotum? It means that you have a myofascial problem with referred pain. For levator of scapula, the muscle that elevates scapula, it gives a referred pain on all the scapular region. So all the scapular region could be colder, but not all the hands of the patient. Just on the regional or just on that local. So you have the hotspot on the muscle, the source of pain, inflammation, involved going to a direction, but limited to that region, represents the referred pain of a myofascial problem. So, but if you found difference, a complete difference on the thumb or the third or five finger, it be more probable to be a radicular problem or a very early radicular problem, okay? It's the same for the lumbar. So when we have a L5 involvement, you can see the big toe difference temperature. So the big toe is the main local that change when we have a L5 radiculopathy, and the calf is the main place when we have a S1 radicular problem. So it's very important. No mind if patient have no pain, not complain of pain on the hands or on the foot, but if he has cervical pain or lumbar pain, you must do that because the treatment is different and you can prevent a problem in the future. So I saw many cases.
¿Cuándo vas a terminar?
¿Qué precisas?
I saw many cases where the patients didn't have complaint on the hands or on the legs, and the doctor did the treatment correctly or full treatment, and after 1 year or 2 years, the patient had a sciatica or a radicular pain. So we must take care of that. I answered your question, Jen? Yeah, okay. Let's see some example here. There's another concept very important for diagnosis is the angiosome. What means angiosome? It means the block that involves the nerve, the artery, and the nerve. So it's the final segment of body, like a domino, we have these pieces connected, but it's possible to separate the body on segments with this segment with the same main artery, main vein, and the main nerve fibers on that local. So when in the practice, it means when we have a cold leg, could be a sympathetic problem or a radicular nerve problem, but also could be ischemic problem, depends on how it looks. And when you have a warm, also could be nerve, could be a vascular problem, especially venous problem, okay? So we must all time, when we see something asymmetrical, you have the basic two ways, artery, vein, or the nerve. And the lymphatic, sure, lymphatic is very close to the venous problem, and you can also put together with the venous on this evaluation here. A little more, we give some interval, but I want to go to show these slides before. What means complex pain? It means that you have some components of inflammation, typical inflammation, with mixed with neuropathic pain, and this is called complex pain or nociceptive neuropathic. And so for nociceptive pain, it means that the problem is an inflammatory problem, could be chronic, sure, and it's related with a hot spot on that place. This is a paper that we published here with Denise. She's a doctor and she studied orofacial pain. And this paper, we proved that it's possible to see hot spots on the face, especially patients that have triggers or myofascial trigger points on the masticatory muscles, and it's very interesting. Oh, let's see this image before the interval. And can you see here, there's something wrong? Let's see who will answer that. Can you see, Linda? Oh, what, do you can see something wrong with that on this image?
Well, I'm not looking at the color as my massage therapist brain kicked in, and I see a little bit of turning over of that right shoulder, so a little bit of imbalance. That's usually the first thing I'll notice before I start looking at other things. I don't know. I mean, I see a lot of hot stuff, but
I will put on the movie here.
okay.
Let's see. What's your first impression on that?
I still see that little bit of tilt in the body.
What? So it's very important to see, the first thing is to understand the complaint of patient.
Mhm.
Where is the complaint? Because if you don't know where is the complaint, it's not good to try to answer the patient, to say there's something wrong. So we must to be very clear what's happened. The patient says, no, I have a problem on my left shoulder, and the left is the main problem, blah, blah, blah. So what you can see here on the left shoulder, the left, there's something different
Left shoulder.
here. Look like warmer. Please point me, where is your pain? So the patient go there, put the near of that. Oh, we have a hot spot here. Let's see, let's understand. Could be many things, but we localize something wrong that we need to review and okay. But imagine on this case, same case, the patient say, no, my pain is not on the left, it's on the right side. Baba, and now, what will you do? Did you have this experience to think the problem is on the warmer, but the patient says, no, it's not here. It's on the colder place. Did you have this experience before?
I've had that experience. But again, I'm looking at it from from the muscles, the musculoskeletal. And so when I see that, and again, I cannot diagnose, but when I see that, I'm normally seeing, and what happens when we're working on the body massage wise is you have to correct one side to work to get the other side to calm down, almost like a referred pain syndrome type thing.
No, you're right. I understand. So no mind, sure, it's correct. You must to balance. No mind is right on the left. You must to balance. It's right. So you are going the balance. The balance is the regular that everybody. But it's interesting, independently if you're a technician or not. Most of technicians in radiology, for example, they understand there's something wrong, that could be a pneumonia, but they don't do the report. But most of the time, they see there's something wrong. So it's good that you understand that something wrong or what's happened, or but sure, taking care of what you're saying. But here, if the patient says that he has a problem on the right side, you must take care and see, oh, it's not a hot spot. It's not a hot spot. So the area is more colder than the left. So when we have a region, a colder region, most of time could be referred pain or radicular, a radicular pain. In this case, what do you think, Jen? Is a radicular or is a referred pain? What do you think is most probably on this situation?
I'd want a better image of the hands to see if that's a cervical referral, because your left hand is obviously really cold, but I don't know if that's just by the movement of the patient. So we'd look at the hand to see what's going on in that neck.
Yes, it's not related with the movement. Sure, you must should take care to confirm, but no, it's the problem here. So here is the problem. So you can see that it's cold, a little more colder than the left side, although we have a hot spot here, but the problem is the right. But if you take care, looking at this image, you can see that the hands is totally different. And here, especially on the third and fourth, fingers is more hot than the left side. And what it means that it means you have a complete problem, complete. So it looks like much more a radicular problem than only a referred pain. So I will not think only, it's just the myofascial here, referred pain. No, it's something, it's maybe is a compression of radicular nerve and involving maybe the 6, 7 on the right side. It's not a great movement. And this change is so evident and almost impossible to be a referred pain that change so much the temperature of the hands, okay? So it's so significant here, so evident here that the most common situation is radicular or a compression of the nerve from the spine or maybe the plexus, but it's something complete. This is important, okay? So we must take care here. First, where your complaint, left or right? So this is the most important. So if you find something hot, where's the patient feeling the pain? Okay, you found the problem, inflammatory neurogenic pain, could be a myofascial. But when you find something cold on that region, you must move your camera far from the patient to have a full idea or the idea of both hands or the both legs in the same image and trying to see if you find more difference. And in this case, the hands, okay? Sure, we can look in with another colors or adjust the temperature of the arms and because it looks like symmetrical, but if you review the contrast, maybe you can find that it's not so symmetrical. But here is sufficient to understand on the first, you have a first idea or first impression that something that could be related with radicular pain. Okay? Any question?
Yeah, I was going to say that this patient seems to have both things. If she came with the pain in the left shoulder and you palpate this hot spot and she says, oh, this is my pain, you have probably a myofascial pain. And even though we look at this image and we think, okay, she may have a radicular problem in the right hand, probably if she doesn't complain, it's before thermography can show us the dysfunction, sometimes years before it can give some symptoms to the patient. So be aware about this. You can take notes and say, like Dr. Brioski said, ask the patient, do you feel anything in your hands? Do you feel like cold hands? If you feel like paresthesia or something like that, and just note, because maybe 1 year, it happens with me with two patients, one 6 months after, another one 2 years after, came with symptoms in the hand, and we saw it before. So you have to, if you're a doctor, you have to take the decision if you can explore more about this diagnosis and initiate a preemptive treatment. I think that is the great value of thermography.
And also, it's very different. If you find only a trigger point, is less serious than when you found something radicular like that. But this is more serious, more advanced. We must take care. Most of people will treat here, the cervical, try to release this is one option. But if you treat only this region or think, it's the problem is the myofascial, you not release the problem, you will not solve the problem. So the treatment most of the time is different from if you have a radicular or myofascial. So it's very important to map for for who will treat the patient and answer the question. So the question here of patient is, I have a problem on my right arm. What I have, I didn't find nothing on the regular exams. The answer is you have a cold arm on the right side, cold scalpel, and it looks like a radicular or involvement of C7 nerve on the right side. This is the basic question on this situation. Okay. Any comments? Belém, do you want to comment something until now before we give a interval?
No, I think it was really clear, and also so in the video was great in order to take some ideas to proceed with our patients. Also for them to see the images would be really great in order to get the face of their pain. So
Okay.
this would also be very good.
Okay. One more question. Jen, no? Okay. So I'm doing very slowly for you to see, to think, to make questions. So we have other opportunities to have course specific with Dalia or with Belém, with Elizabeth that's here. So, but this is the first time we are trying to pass in our experience and trying to understand what you want to discuss more. Okay, but let's interrupt now. What do you think? 10 minutes, okay? 10 minutes, and we come back.
Yes.
It's okay for
Then
everybody?
to refresh, to have a cold water.
Yeah, so take a shower,
Take a coffee.
take a coffee.
Take a coffee.
So it's 4:12. We return for sorry, my time is 12. In 10 minutes, so 22. Okay,
Okay.
your time 22. I don't know your time.
Thank you.
Thank you. Stop sharing.
Uma coisa que eu observei, né? O grupo é
Okay. Okay, Linda is here. So don't worry if you're having so much information, doubts, you can review. We form up the course, how you can access again this video, and we are here in a group, in a WhatsApp group, so you can send your doubts. No minds the next week. If you want, we all of us will be there to help to answer and contribute for you to do the exams. Are you liking, Linda? It's okay for you? You understanding?
I'm learning so much.
Yeah. So this is why
Yes.
I don't want
I wish I
because
could have done this a few years ago.
okay, sorry.
Yes.
Because most of the time we put a lot of information, blah blah blah, and during the EET meetings, I see the face of people all the first slide I didn't understand you the
Yes.
15 slides and so
I enjoy learning. Yes, I
Yeah.
always like to learn.
all of us here, all of us here.
Yes.
Okay, thanks so much. And I'm not talking so much with Ira because she's, I don't know if she's sleeping, but people there is sleeping now.
Yes, there's some people missing that were before.
Okay, let me show some examples. I will show you some examples of diseases that are very common. And after this, we are talking about position, okay? So take care, attention to the case that I will show. And we return for the clinical aspect. Oh, sorry. Are you seeing my screen?
Yes.
Okay. What's that? This is an example of hotspots on the back. Third, it's not the common, the regular image, because most of time you don't do the visual and infrared, but it's possible to use some softwares that put the mix overlays. Okay, it's interesting because here's the photo of the back, and the overlays, the infrared overlays only of the hotspots on the skin. And these are common examples of trigger points. And adjusting the scale, in this case, and seeing the colors on the scale, it's possible to understand between these four trigger points, this one on the right side is the most intense hotspot. So most of the time, this is the main local of pain. Sure, you must to ask him, confirm with the patient, as I showed on the case before. But it's interesting that you capture the image and adjust the contrast of the image, and trying to see which ones is the worst or the more intensity, more bright, and trying to define the other ones as a round shape like that. So we have the scapular, split scapular left to right, and rhomboids here. And here's another example of rhomboids. And you see here, it's not isolated hotspot, but many of them. So it's multiple. Okay.
Just people remembering for you to speak louder, please.
Loud. Okay.
Yes.
Okay, sorry. And here you have the hotspot of the scapular lift on the right side, the elevator of the scapula on the right side. But looks here, the scapular region is very colder than the left side. So here is an example of the hyperid pain. The source of pain is here on the hot spot, and here is the hyperid pain. So you must to ask the patient, where is your pain? So if your patient points here, okay, we found the source. But sometimes the patient will point this cold area, and you must to take care, because here is not the source of pain, it's just a hyperid pain, and the source is the hot spot more close to that region, and in this case is the elevator of the scapula on the right side. Here's another example of myofascials, different color, but the idea is the same. You can see this is the most warm, and actually we are using 3D images like that just to have idea where is more warmer. So some softwares that do that, just you to know. And here is the cervical, posterior cervical. There's a contraction of the cervical muscles, and you see here, very interesting shape. Also, it's possible to see on the 3D image, but the idea is the same: asymmetry, and is in the way of in the direction of the muscle. Here's another example. Sorry.
Sorry to interrupt. Jan is having a question.
Sure.
Maybe just to wait till the end.
What's the question?
Jan, go ahead, please.
Go ahead, Jan.
When you're doing body imaging, are you setting this at like 12 degrees, or are you setting it still at 8?
Are you saying that the values here on the scale? Is it your question?
She wants to know about the temperature window, I guess.
Yeah, generally we do body imaging at 12 to 16, and then like breast at 8.
Okay. When you're just collect imaging, it's okay. It's a good interval. But when we are capturing the image and trying to understand in the same time what will happen with patients most of time is a dynamic. We need to do this adjustment in our images because if you change the color, if you change the distance, or depends on kind of problem, you have different intervals for adjustment. So the aim here is to give the best contrast to see the problem. So depends for these colors here, I use 25, 13.8. But if I change the colors, for example, here is another different color, and it's the best contrast is different, totally different. Is here 25, okay, but here's 13.6.8. So if you change the color, which the interval is different because the best contrast is not in the same window, okay? So it's a dynamic adjustment when you are doing the interpretation at the same time of capturing the image. Okay, Jan, did you understand?
Yes, okay.
Okay, but if you don't look in something specific, you can follow as you told with the protocol you told. No problem. It's possible to adjust this and find for the problems in a second moment. Here's something interesting, especially what you're talking now. For example, here's the back, and you see a large image with red aspect, but it's not well the contrast between this center or this regularity on the vertebral and the muscle, for example. And with 3D is the best or the most possible way to adjust the contrast of any kind of image. It not means that you need to do that or all time, but it's just an example that sometimes you must take care when you are interpreting image because you can think that is something so big or something larger like that, but could be something very specific or depends of the contrast. Here's another example with other colors. So if you change the color, you need to change the contrast. Here's a cervical disc, just to show. I'll just show some examples. Cervical discopathy. It looks like a center image here on the cervical part. It is in the lumbar, and you see a round shape in the middle line on the strip line. Most of case when you have this round in the middle, it's most of time related with discoarthropathy. Okay, so here is a discogenic problem, and here is a degenerative problem related with the facet joints. So different, it's not in the middle, but it's paravertebral here on the left. So what is important? The adjustment of the contrast. So if you use the same interval for all images, would happen that you will not find all the problems. So it's interesting that you learn to use another colors, learn and make dynamic adjustments, and especially to understand what is the complaint of the patient to find that. Let's see if I have another example. Here, for example, it's the lumbar region. I have a difference here on the hip joint, and the symmetrical is more warm. So what it means is neurogenic inflammation, a source of pain, something wrong with that. And in this case, the patient don't have pain exactly here. He has pain on the right leg. So it's possible to try to see that it's a little more colder on the right, the calf.
Fala pouco mais alto, Marcos.
The calf, and it look more colder. But it's interesting that you have these maps as reference to understand that the structures here would give referred pen for the thigh, for the calf, for the legs. So when you found something cold, isolated, you must have these maps to looking for the source of pain. So a patient could have a problem here on this the posterior thigh, only here a cold, and the source of pain will be here sacrospinous joint problem. So these maps we use a lot when we are evaluating musculoskeletal pain on patients with myofascial problems. Here another example, the patient point where is the problem. So, but don't leave the patient touch the skin, give him a pencil or something that he to avoid the direct contact of the skin. But it's very important that he points where is the pain and you confirm if there's inflammation on there. Okay, it's different, depends on where he puts the hand or he points. We can have different diagnosis, but it's totally different when the patient pointing and you're not seeing. It's totally different when you see that his point is actually the hotspot. It's more, we believe more on the patient and what's the problem he has. Is another example of sacral leads. It's inflammation of the sacral joint on the right side, very high temperature, very asymmetrical. Here another example. So it's interesting that this patient is a patient with a chronic pain, general chronic pain, full body. But what's the most important we found here? Inflammation on the sacroiliac region. It's not only a fibromyalgia patient, but a patient with autoimmune disease that we call spondylitis ankylosis, inflammation from the sacroiliac region with other degenerative problems. Here's an example of the shoulder. You see, where's the pain? On the right, look like inflammation on the right side. If it's on the left and cold, could be radicular or cold shoulder. Go. Here's up. I'll talk now about the position. See how interesting is this position here. Here is the shoulder, the right and the left, and the camera is looking the upper part of the shoulder. It's not the front, it's not the back, it's not lateral, but it's the upper. And how is possible to do this image? You must take, asking for the patient to lift and doing the image. And with this image is very good to evaluate the shoulder. Okay, is maybe it's not common at US, but we do in our protocol is very commonly used most of the time. And it's more easy to understand, to see if it has a rotator cuff problem, and also is good to evaluate the difference, the asymmetries, the region of interest. You can choose better this and evaluate it.
In fact, Linda was asking you about the proper positions in order to send a patient to a physician. Maybe you can explain better, Linda, your question.
Okay.
Yes, I was following up too with what I think it was Jan that had said something. You know, for me, I'm not a physician reading the imaging.
Okay.
And because we stick to this certain protocol of how our clients stand and which images fit within the program that we use, seeing this, I feel that we're so limited. And then you were talking about, she was asking about which temperatures that you were taking them. And so you had the images where they were done with different colors and some were closer and some were further. Wouldn't it be better for us to
Uh,
send several images to the physician? Wouldn't they be able to read that imaging better?
Good question. We must understand that size is not something rigid. You must understand that the things that people are doing actually may change tomorrow. And so one and go back, oh, the past was better. And all times will change. So, uh, uh, and it's what we're doing now. We're trying to upgrade that and discuss about that. And as I told you, we don't have a fixed or a fixed rule. Don't do that on that. So we are in a moment to change experience and try to increase. So after this course, I'll show some now some positions for you. Maybe you can try to add some new positions if you want, or try to experience that. But sure, don't lose what you're doing. But could be interesting. We rethink to discuss again in another moment. And this is the moment for us to look for new things. So infrared image thermography is not something rigid, and it's not stopped on the past. It keeps going on changing, and maybe the position here may be changing for the future. I'll show some positions here. So we have this one, and that we took the front image and of the upper body, and also in the sequence the lower part of the body. But what the most of time we do, the anatomical position with the hands, with open hand, and a little not so near from the thorax, but not so far, just in a normal, relaxed position. But on this picture here, we took the image of the face. I know that sometimes people cut here, but it's very important to have the face on this image to understand if the problem goes down or goes up or that. It's good to see the face on this position, on this protocol, okay? And here is in front, and there's a little not in contact with the thigh. That is not in contact. Also the knee is not in contact. And here you can say, oh, but the hands is here, and look like that's cut. This is why, because we have a software that we put both images together and reconstruct the full body. You have this function in all FLIR softwares. It's called panorama. Panorama, it means that you can thumb both images if they have an area of intersection. In this case, the intersection area are the hands and the hip. So the hip is part of the hip is in the upper, and the same part is in the lower part, and it's possible to reconstruct that. I can show you. Let me see here. I will open an example.
Does the software have the grid on so that you view that while you're imaging?
No, it's not. You can use the grid or not use the grid. The grid is good for you to learn and to position better the patient. We have a software that has a grid, but there are some cameras, portable cameras, that you have the image on the camera, and we put an adhesive, and the adhesive has the
grade.
The grade. Great.
The grade.
Yes, thank you.
It's especially good when we are learning how to make the right position for the camera and the patient. After some years, we don't use, but it's good for your you teach some some doctors. I don't know, you said that you also have some alunos, gente, como é que é o nome de alunos?
Students.
Some students, yes, very good for the students.
Let's see, let me see. Oh, for example, I have this image, and after I have this image here, and in the software, I have a function that's panoramic, and it's possible to connect both images in one. So,
Yeah.
Mais alto, Marcos.
here or here.
Is this your software?
No, it's FLIR software. There are many of them. It's very common. It has 10 years, the software. More than 10 years, 15 years, we have this option. And it's very good this because you have in one image, all in one image. So, and it's very good for comparison because here, let me show you. Here has studio softwares, but other companies also has this option, so it's not uncommon. So I do again here. But when I start to use this, for the full body, it increases a lot the diagnosis. Increases a lot. I understand much better what was happening with my patients. So many things open here.
Linda, with the software, so with most of the softwares or Young, you can merge two pictures. It's a way of merging them. Sometimes it's not 100% right because of the angle you use. But finally, you get used to it. You take the proper angle, and then you are able to merge them and have a really nice picture as the one already showed on the screen.
Yeah, here what was possible to join because the patient had some movement, and so you must take much more care when you're using this option here. Because we didn't have the right connection, and also combination of the camera or the movement of patient. But here was possible, and show you. And for example, now I can use the same interval, the same scale for two images at the same time. You see? So if I did a full body like that, maybe I need 5 meters distance or more, and the image will be very low resolution seeing that. And when I use this option here, I can do the image more close to the patient and with a better resolution aspect of that. And also I can evaluate all in one color and adjustment of contrast. And it's much more easy, okay? In this case, I can see that symmetrical, more temperature on the right side. This is the iliacal muscle. And here's, we have both sides, the adductors. And you can see the difference on the shoulder here, hot. And there's a difference on the arm. So probably she has a radicular problem. Let's see the hands. Now here, you can see that there's a difference on the hands. And on the third, so look like a C7 on the left side. It looks like, but you need to know the complaint of the patient, okay? This is one image when that I interpreted. But if we have other images like that one, let's position here, let me show. Oh, so many things. Okay. I will do the adjustment for the hands. And you can see starting to appear the fingers here and not here. Now appears on the both sides, but there's a interesting difference on the left side. And if I change the colors, let me use another base color here. This, for example, you have another way to understand the image. So it's possible to see that it's really asymmetrical on the posterior part of the neck. So it looks like something that comes from here. So it's look like it's radicular. And you see that the blue area, the cold area, is totally different. And if I do another adjustment for the arms, for the arms here, you can see that it's much more colder. There's a large colder area on the left than on the right side. So depends what you're looking for. The adjustments are different. So I'm not thinking it's 5 or 8 degrees. I'm just looking the image and trying to find the better aspect or the better contrast for what I'm looking for. So if I stood in here, the cervical, it's good now. I can see maybe a myofascial problem on the left side. Now the arm is not good, so I need to change a little here until to appear and see it's more colder here. But the hand's not good, so I need to move the scale.
It's a dynamic.
It's very dynamic. All the time is dynamic. You cannot use only one interval and give the results the same way every time. Okay? Complex. No, it's just training.
Why did you have the emissivity at 95?
No, I can change there. Maybe who made the caption, it was wrong. It must be 98, but I can fix now and put 98. So.
Okay, but would that adjust or change your image at all?
Yeah, I adjust and I send a message and say, oh, the next time, take care. You must, or not take care, but I say, please help me because I don't want you all the time to fix these things. So, okay, but I can fix no. Okay, did you understand me? The who kept the image, send the images if in a 95 emissivity on 0.95. And there's no problem because I can fix this on the software, put 98, and I just do a call and ask it to correct this the next time.
Dr. Marks, sometimes I saw that I do this without taking care because I use 0.95 when I'm going to start the BTT, take image from the BTT. And sometimes I forget to change to 0.998 and I have to make this adjustment.
Yeah, let's try to explain this to Jane. Jane, when we need to do this kind of image of face here, and we want to calculate the high temperature.
Não está aparecendo só você.
Okay. Here, Jen, is the face image. And when we need to calculate the high temperature of the face, especially in this area of the eyes or the brain temperature, we fix the emissivity to 0.95. Is an exception in the body. So there's some areas of discussion. So most of the time, 98 is the best emissivity choice. But there are some specific areas of the body that is better to have this, to fix that, okay? But we don't worry so much with this because most of the time we don't measure the specific temperature as the eye here because here in the eyes, I can't say if it's normal, it's a fever or hypometabolism. But as like the shoulder, for example, if we have a 13.5 in the right shoulder and the other one is 13.4.5, I do the difference and calculated the, for example, 0.5 degrees difference, and no minds if it's 95 or 98 the emissivity, the values will be the same. Okay, but if you're measuring the absolute temperature on a specific point chart, you must to correct the emissivity. But we can talk with this. It's advanced detail and it's not so
My
relevant
camera
to
has to be
practice.
set. I can't adjust that kind of.
No, you can do it on the camera, no problem. You can adjust on the software after, understand? On the software,
But
you
not
can.
on the images after.
Oh
Okay.
no. Oh, okay. I don't know. Most of the time we do that after. But okay. It's good to know about. Yeah. But let's see here. So the upper, the lower image. So the hands are here, the hands are here. It's more easy for us to connect the images. Front, the distance depends of the lens. Most of the time is 3 meters. Let's see. Here's the back. The hands open.
Não estamos vendo, não estamos vendo.
Ah,
Tá
não,
parado.
não. Não voltou ainda? A internet.
Ainda
Não.
we are still with the
Yes,
now.
não. Ok.
Voltou?
Sim, voltou.
Internet. Imagem das costas?
Sim.
Okay. So the back here. So little, not so close to the trunk. And
But full screen.
não tá
Tá
full screen.
faltando a tela completa.
Agora apareceu completo você. Isso vai mudar. Agora sim.
Deu, né?
Agora sim.
Okay. The back. So the arms are not so full contact with the trunk. The hands are open. If the patient has unbalance on the posture, for example, the right shoulder is more upper than the left, you must should keep on this position. For example, we have some serious scoliosis, things like that. We do, if this is the natural way of patient, we keep this in that position. Okay, so if he has a serious scoliosis, for example, we're not fixed to do the image. We live in his natural pathologic position, because the pathological position is diagnostic for us also. But here's okay. It's not the case. And here's the legs. So the legs, there's no contact with the knee. We do this perfil or lateral view, the lateral view. And here we put the hands in front of the patient like that. Why? Because it's very interesting to looking for this region here, the axillary region, because most of the time this region is a very common to have problems like intercostal nerves or zosters or serratus muscles in this region. So it's very interesting to show this area here in the axillary. And the hands is goes ahead of patient with all the fingers open like that. And the left is not appear on this image here. So we do the upper, followed by it's a family, the same. So the upper and the inferior image. In the inferior image, we don't leave the foot separated. We put together. So let me
Mhm.
see the next. No, it's not here. But we put together just to appear one leg and not both legs. Okay. Any question? You do different, yeah? How are
Jen?
you doing, Jen? These images. Do you do the lateral
I'm
view?
wanting this software. I want a
Sorry?
new camera.
Do you want a new one?
I
No,
want a new
sis.
camera with that software.
No. Oh, I give you a tip. It's very cheap compared to the other cameras. You can find the C5 cameras, handle cameras, or also cameras in cell phone. To train that, I understand you have a good ones with high resolution, but it's good to have a base one also for this situation because you become more free, more fast. You can do much more images. You can do much more point of care images. And these handle cameras, I believe is $400. You can buy that on the US. Okay, it's not so cheap, but it's not so expensive. So yeah, and it give more. You can use all the softwares, and it's inter here.
Was in the early 2000s when Micro Health Systems was selling cameras. They had microns instead of FLIR. Micron now is bought out by someone else.
Mhm.
Okay.
But I love this software.
Yes. This flip camera that he's talking about is the C5, if I'm not wrong, and this is cheaper. Dr. Brioski? You have the one, but he's talking,
Yeah,
this one you can put in your cell phone, I think.
Yes.
exactly.
I
So
have
they-
that one, but I don't have decent software. No, I
Yeah.
have that FLIR, but the software is so limited.
Which
But
one?
I sent a link for the FLIR's studio in the group. Then you go there and see
Great. Yes.
the link.
Jan, do you have an iPhone?
Yes, I have that camera that I use for point of care, but the software is too limited.
No, the
Yeah, but
software in the camera is limited, but outside the camera, you can do all the things we show here outside.
Yeah,
exactly.
but that camera won't give me the ability to get the resolution that you have.
Yeah, you can change it, but listen, there's two ways. Once you've got the software on your iPhone, but you can also transfer the pictures to your laptop and then
And you
use
do
the same.
FLIR tools.
Sorry?
Are you using FLIR tools on the laptop?
Yes.
Okay.
And you
Because
can use it as well.
FLIR one on the phone only has like 3 palettes, terrible palettes.
No, but on the iPhone, you have to upgrade the version because there's a lot of actions. But anyway, it's much easier to edit the pictures on your computer because on your computer, FLIR software has a lot of options, including the panorama option you loved. So don't wait.
Yeah, I'm
Okay.
Download
waiting.
the FLIR version tonight.
Liberty.
Well, I use that camera for a quick look, but I don't like the way that it's set up. But I've not taken it into tools.
No, you need to train more with these cameras. You love that. All of us
Yeah.
here, most of us here have both professional and the portable one. So when
Yeah.
I travel, I bring my camera. When I have some emergency or something fast that I want to do, blah, 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 blah. I take the pictures, I understand what's happened, and sure, I can use it, analyze after and review, change the colors, I fix the emissivity, doing the reconstruction, panorama. It's the same.
And
It's the same.
yeah.
What
You
is
can-
the last update? What's the last update on that flare?
let me check it for you. You can also
This
use
one.
it on your iPad, Jan, and it will have more options that on your iPhone, because on your iPhone is a really small screen, so it's not easy to do it. Also, the options are limited. So Sidalia already shared the version on the WhatsApp group in order for you to download it on your computer. Then
Okay.
to download it on your computer, you can transfer your pictures from your iPhone to your computer. If your computer is also a Mac, you can just airdrop the pictures. So it's
Okay.
very, very quick.
So the
And
best
then
thing to do is to go to FLIR.com. Go to the
Okay.
FLIR website and she can find all the new latest information.
Thank you.
Yeah.
Yes, I
Sidalia
sent the link.
already-
I sent the link to the group. You can go to the studios and there you open and see. And also if you go to Amazon.com, you'll see many of these cameras there. They are cheap for you. It's less than 600.
Yeah, well, I have the small iPhone camera, but I don't have a C5. I have that
Okay.
the one that she was just demonstrating.
Mhm. That's good.
Just send in your pictures to your computer and download the software on your computer, and you will live in a new world, Jan.
Yeah, yeah.
Thank
Oh,
you.
I show some images from our ambulatory of pain, chronic pain, okay? And I show many interesting things on these photos. Most of them, I believe Sidalia was there on that day.
Yeah,
Sidalia, remember?
yeah.
Remember? And
Yes.
here, let's see here. There's a woman with a phantom vein amputation, and he has
Neuro.
a lot of neuropathic pain here. And I'm using my cell phone, and here's the new camera. The new camera actually is possible to disconnect it from the camera,
Cell phone.
the cell phone, and you can use it separated or put together here. But no minds, but to see how is easy to do the image, any position, close, most of time are close image. And I'll show the image after, but you see the ambient here. There's no room temperature control here. Nobody, there are a lot of people seeing, oh, I said, oh, what's that? But she's seeing what I'm doing. Let's see the next image. I'm analyzing here on the software, and here on the image, I think I have a movie about that. But is the here and the red region is the neurogenic inflammation on the arm, that amputation of that arm. But I have yes, the equipment here. Here's the software of the equipment. So sure, we have rainbow, we have a grayscale with isotherm, so it's possible to separate it, the warm areas.
Do they have inverted gray on this software so that you get a
Yes.
vascular pattern?
Yes.
Because the iPhone camera doesn't switch. So I
Yes.
hope the software does.
Here a good example here. See, cell phone, and it's so close with patient, but see the image here. On the left side, here's the gluteal area, the spine, but yes, on the local pain on the left side. There's no control of temperature here, but I believe it's 21, 20 degrees. Sure, you cannot do, it's not recommended to do more than 23 Celsius degree. I don't know how much Fahrenheit is that, Billing?
23?
Yeah, for them.
Deixa eu procurar aqui.
And see, Jen, I'm doing the contrast here, and it's possible to identify easily and very fast the problem and touch the patient of what is happening with him. So he's not naked, full naked, but it's possible to understand, and he exposed a little.
70,
How much?
73.4 Fahrenheit. 73.4 Fahrenheit is the standard temperature.
And in this case, Jen, for example, I'm seeing very fast that's a problem on the back on the left, okay? But remember, I told you, when you do, and then when you find something wrong on the back, you must to do the
Good.
so yeah, the plantar image. And here it's not so clear because of the position, but in the calf region is not same color. It's not so good, but it's in it's red here. Here's in black, but it's possible to see that the left is not the same on the right, and it's not appearing the gray toy. So here's so it's not L5, it's S1 problem on the left side, and it's possible to see very fast 2 pictures based on the clinical complaints, and here on the left side. So in less than 1 minute, I confirmed the S1 on the left side. And sure, everybody did the clinical exams, saw the reflex and the other exams, right, so on. So you have a fast answer in a no controlled ambient temperature.
Okay. Temperature.
Elizabeth, you was there also, yeah? Remember?
Yes, she was there with a big camera.
Yeah, let's see.
I think I make these photos and
Yes,
the
yes,
movies.
yeah. So let's see another picture here. Very good. You can see. Real time. You saw here on the end. There's asymmetrical and more heat on the left side. So fast, so easy. Because what's the secret here? To do the dynamic adjustment of the contrast real time. You must training the adjustment. If you train this in, so most of you have experience with infrared image. So 2 days, 3 days, you're doing this in outpatient all the time. So this is point of care. I don't recommend for report. I understand for report to do a research, to compare treatments, you must take a lot of care of that. But for a fast or a first impression, diagnosis impression is very interesting. Okay, and sure, it's possible to transmit the image or to mirror your cell phone to a TV or to a monitor, and it's very easy to do that. Here I'm doing another thing, Jen, is actually there's some new software that you can choose the image like that. Choose the image, the cell phone. So I did that image, and the software describe the image and bring you an initial report of that image. If you put, for example, the history of patient, woman with 66 years with pen, and you ask for the AI will describe the image, the intensity of the problem, and give you a base to report or the first idea for you to review, to see it's okay or something different. Here in real time, the woman with the pain and amputation. See here the red spot. Take attention. I'm looking for the head spot.
It's the amputation stump.
I'm looking for
does the amputation retain or go back to a normal temperature? Because a lot of times I've seen stub being cold.
It must be cold, but this patient has a lot of pain and phantom pain. And one of the causes, or it's most common to have a neuroma, is a tumor of the nerve.
It's called the stump.
Yes, and it's an inflammation. So I'm looking for the inflammation on the nerve, because we have we put botulinum toxin to treat this kind of pain. Okay, but it's a new kind of treatment. But I'm looking for the inflammation. High intensity, the head spot here on the image. And with my finger, I'm trying to go where the hot spot is where to confirm. Okay, it's amputation, but I can do the same for myofascial pain. That is more easy to start, but could be.
Can you get a visual picture on that camera so that you can then correlate the visual to the infrared?
Yes. Here, the image of these equipments, they are multispectral. They is a mixture of visual and infrared at the same time. So the camera is not so low resolution. This is not the point, because you have a high resolution visual that gives you a good contrast, and you just need to understand if in that region there's a hot spot or not. So don't worry so much with resolution with this camera, okay? But if the camera was only infrared, sure, it would be a problem. But actually, they are not only infrared, they are a mix of visual and infrared in one device. It's a multispectral multispectrum function. And it gives so you can have a more cheap camera with a better. Okay. See here the hotspot.
Yeah.
It's very easy because I put on the right adjustment, but it's dynamic. You must find and to train a little. More circulation, more inflammation. I save. I can move it. I save the picture.
Now, is that the nerve root irritation from the amputation, or is it old?
Yes. Is right there. And here is important for us because we need to put toxin botulinum exactly on the region. And sometimes it's very difficult for the patient to localize it on the right, on the left. So in this way, it's more easy for us. But it's the same situation for shoulder pains, back pains, knee pains. It's very similar, the approach.
Would that be considered a nociceptive pain or?
No, it's neuropathic pain.
Neuropathic.
Let's see this situation.
Jan, he enviado para você. Disculpe, sorry, I was talking in another language.
Okay.
Jan, I have sent you on the WhatsApp group the last version of FLIR tools for your iPhone, right? So that you can also.
Here we have another interesting situation, Jan. we found something hot on the left calf, but looking better with the camera and then making the right adjustment of the contrast, it was possible to see that it was not, the hotspot was not a trigger point. But here is a vascular, it's a vein, and we are not using the grayscale. I try to stop here. Oh, it's not so good. Let me put it here. So, you can see that's real irregular. It's not a hot spot. It's a vascular. It's a vein not visible in a rainbow scale, and very clear this situation. Yeah. So it was not in a good adjustment in this moment. So there's something wrong here. And with my one finger, I did the adjustment in the scale. And here I found something wrong.
How would a clot demonstrate?
Sorry. How what?
How would a clot demonstrate? Deep vein thrombosis.
No trombose.
Okay. It's not a deep thrombosis. It's not a deep thrombosis. But when we have a deep thrombosis, TVP, we have a very significant difference. There's a lot of venous aspects in all the count. It's something with high temperature, very visible on the infrared, and it's not just something so close or so specific, you understand? But in this case, he didn't have pain. It was just some normal fine, not something that he really was complaining about. See here is another image. And here's very interesting because we are comparing a professional camera with high resolution, expensive camera, with the low resolution camera and more and less expensive. Sure, it's much better to see the image in cameras, professional cameras, but it's possible to correlate both. Here, we are doing the image of the planter, and you see that it's very close, the image. There's not so much difference.
Yes, it's very, sorry, Marcos. It's very important, your comparison, because we researching in hospital pediatrics, we compare scientific cameras with FLIR1 cameras, and we did the same results for quality images. Exactly right.
Great.
No difference.
Thank you. Because, Jen, we are not measuring the temperature. Most of the time, we are trying to understand the shape or remember the case when I told you that there's a difference temperature on the calf. This is the guy with the left side with radicular pain. So the diagnosis here with this low resolution camera is the same as with the professional one. This is at P540. So at the end, you will have the same conclusion. But sure, the professional camera, the image is much beautiful, it's much better, it's more easy. But at the end, with a little experience, you will reach the same result. Okay. And it's good for us, especially that you don't limit our friends and the people that would like to improve their acknowledgement. And so, because in the past, most people didn't started to do infrared because they were very close or were influenced oh, you must to start with high resolution camera, etc., etc. And most of good persons didn't take part of that because they were inhibited by this kind of thing. And in practice, we saw that it was possible to reach the same diagnosis with low resolution cameras, and a lot of people understand that. And we saw many more people doing and interested on infrared. Any question until here? It's okay. Did you see, Linda?
I have a question.
Yes, thank you.
This is Julie in Las Vegas, and you're right. After 5 years of imaging, when I first came in, I had the impression that the FDA in the United States had strict protocols and that I had to get the 640 by 480. But like I said, I recently just purchased a FLIR camera, and it is kind of frustrating to think that I spent so much money 5 years ago, like 30,000 on a system. Yeah, and now I'm doing it to compare, and you're absolutely right. And it is very frustrating that we're led to believe that the FDA has such strict rules when there's really no boots on the ground to control it, honestly.
Yes, I understand. I also spend a lot of money with expensive cameras in the past, but I understand it was something that I need to see, to learn by myself, to understand by myself, without any influence from the sellers, from the industry. So by the time I was discovering this by myself, and sure, pass this to my friends, and I had some resistance about that, sure, especially from the industry. But
Yes.
now they understand. So it's impossible to forbidding something that is good. So if something is good, help people, save lives, is portable, is cheaper, it's impossible. You say, no, you can't do that. It's impossible. And
So
someone will do it.
do you think that, because I think what I've seen over the 5 years is that
I think that
when
the
it comes
important
to
thing,
the
it-
breast only is when it really is critical about the higher resolution. Do you think that that's true?
I didn't hear so. I had some
Not
problem.
if you're doing controlled studies. He's talking primarily point of care. Controlled studies,
Yes.
environment is different.
Okay, you will find actually in the last 5 years many studies with point of care. It's the most common camera is the FLIR one. So you'll find a lot of papers in plastic surgery, also in breast screening, and pain. It's something not so. There's no the RCT, the random clinical trial, something so big, so sophisticated research. But there's sure, yes, there's a lot of papers with these low resolution cameras. So we have evidence that it has a great potential to be used as the same as the high resolution cameras. And it's increasing the numbers of these papers because many researchers, many doctors are saying, oh, I can do this with basic camera. Yeah, and it's good. And I believe we can, sure, we need to, we are open the doors for more people to do and to help the patients. But we must understand the limits. The limits is about the region, the resolution, the limits about the control temperature of the room. So, and when if you do a paper or if you publish, you must to explain exactly the methodology, if you control, if not control. And there's no problem, but you must just to say, and the science must to go on. Okay, Sidalia, can go ahead.
yes, I believe that with this development of new technologies, the devices will be more easy to deal with. However, it doesn't mean we don't need to know more about what we're doing. So as the technology goes like advanced, we need to be more professional. We need to learn more about how to deal with these scientific cameras in an easy way. I mean, we have to be very careful about this, because it doesn't mean that anyone can just buy a camera and do our job, you know. We must defend our knowledge, our study, our work, because even though the cameras is becoming easier how to deal with them, it doesn't mean that we need less knowledge to deal with these cameras.
Sure, very, very good what you're saying. And also, there are a lot of new things. So the softwares are changing, the concept, the application, you don't need to do for a full body exam to study the pain and patient. But you must to describe what you're doing, what the aim of that exam. The aim was just to localize inflammation. Okay, the aim was just to confirm if there's something wrong where the patient have pain. Okay, there's something wrong. The aim is to separate is inflammation or neuropathic. They're radicular or not radicular. So we don't need to say, oh, we have here blah blah blah. No, you can do basic questions. And point of care, the characteristic of point of care is simple questions. You have or you don't have. Is there or there? Is localized or is it was decrease the temperature, so the infection decreased or increased after treatment. So the questions more based, more simple. This is the function of point of care. Answer these questions, and most of the time are not primary diagnosis of a specific disease, but sure is diagnosed. Diagnosed is a biomarker, like the word. It's a biomarker of we have inflammation, no inflammation. Is better or worse? A biomarker. And we can add this information with the full history of the patient. I have another video here for you to see the adjustment. The adjustment of this camera. But it's here on the screen. You see the maximum temperature in the scale, 35.8. You pass, you screen the finger on the screen. You hub the finger on the screen. You go up or down, and here 28.8. Okay. So it's all in the hand. Let me show. Let's see this image here. Here's also interscene. You can see that this toy is much more colder than the left, but this is the patient with the left pain on the left side. Here. You can see very fast, full body or big areas. Turn back. Here the back of patient again. The image of the back. Good question. Let me see here. The position. Let me see. Ask me. No, please. Oh. What's the question about? Please make your questions because I need to close my window to answer. And
no, I was wondering if the AI software now will require more specific imaging.
Yes, yeah, it's
more
better.
Positional, like
sure,
standard studies.
It's better that you follow the anatomic position, the standard position is better Because if you exaggerated or if you incline so much, imagine that you have a photo and you took the photo of your face. Okay, it's easy to understand your face. But imagine someone lifted, inclined, and also in the visual would sometimes be a little difficult. It's the same difficult for AI. AI identify very easy if to the right or the left or the hand or the face. But if you help put more clear, more easy, or you mark with a region of interest what you're looking for, it performs better. It performs better. Okay, and you must understand it's not something to substitute your evaluation, but to help you to reach on the same diagnosis or the same thinking, but in a fast way. So it's doing 2 seconds, and you, oh yes, okay, yes, all right, no, there's a problem here, no, it's okay. So you must review all the time then. Actually, we must review. Maybe in 1 year, maybe not need to review nothing. I don't know. Everything is possible in the next years. Daria, do you have a question?
No, I think that it was really very well explained.
No, because your hands is
Since last time.
There is one question that Jam asked, but I think that I can tell something. For example, she asked if it's the AI will require more precise positions and high resolution to give this the answer. And I believe no, because in your software, we can have this answer with a simple camera. So it depends on the software.
Yes, it's very flexible. He performs very good, but it's not good for you to
give.
It's better to give a good information, do a very clear information to be analyzed. Things. So describing here perfusion on the right side, intensity, possible inflammation on the local. This is
Not for official examination report, you say.
Yeah.
But it guides us to the diagnosis and the treatment. Also the evaluation of the treatment. You can have the images before, during, and after the treatment. And even in another week and the other week, you can follow the treatment of the patient and you can compare the evolution of the treatment. It's very good.
Yes, there are a lot of things that we have in the next months. Oh, here's the back. Position the camera. I'm using the automatic. No, here the image. Oh, very easy test. I'm explaining to the students here. This is why I'm on point. But it's interesting in the point of care is to do the physical examination guided by infrared. Physical examination, a guided examination is very good. Independently if you will do a massage or if you do a needling or if you do a ultrasound. And also if you complement the exam with an ultrasound for diagnosis, oh, I found something wrong here. Okay, you can complement in the same place with ultrasound if you want. So it's very good to see it this way. I'm showing. Okay. That's stop here, and I have other slides.
Você que tá aparecendo.
Okay. Any question? It's okay until now. Remember, during the week, you can review the video, make your questions, send your comments, or send papers, or send comments to discussion, or try to, oh, you said something wrong, okay, no problem. We are open mind here to fix and to learn also.
It's very good to listen about the experience of them, to know what they think. For example, after this class, what did you catch for your practice tomorrow? What are you going to change in your practice tomorrow? What will be good for you to practice that you learned today? We'd like to hear it from someone.
Okay,
Yes.
can I speak up? This is Julie again.
Oh, nice.
And
Julie.
my question is that it seems like this, the environment, I don't know about other countries, but in the US, it is so controlled by what I think of as they lock you into their software, they lock you into their specific camera, their interpreters. That's why I chose the company I went with, so that they just sell a camera, they don't worry about all the other stuff. With a FLIR camera, are there a lot more choices to have, quote, interpreters to help with the technicians to do reports, since they are chiropractors, MDs, professional practitioners?
The question?
Yes, she asked if with FLIR, she's not so like closed for interpreter.
Close.
Yes,
Depends
because
the lens.
cameras, yes, the other cameras, they just say, okay, you only can do this and use this kind of interpretation. Is it what you asked?
Yes.
Yes.
With and I use the names we all know with, Med Hot, Medatherm, all of these ones that if you buy their camera, you train with them and you stay with them and their interpreters. If you're not happy, they'll kick you out. But it seems like with FLIR, there's a lot more flexibility.
Yes.
Okay.
We are not attached to assign a name. No.
Perfect.
We must understand that you are the responsible of what you're doing. So you are in front of your passion. You are in front of your passion. So the decision is yours. The responsibility is yours. If the camera is innocuous, no touch, blah, 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 okay. So the fabric, there are many industries, many equipments, many softwares, blah, 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 blah. But you have the opportunity to test anyone if you want, no problem. And maybe next year we have a better equipment or new companies or new software. So the most important is the patient has the best of you. So you must be freedom to choose what you want, freedom to research, freedom to find new things, freedom to pass in courses, you in the future for us, pass your experience. So this is important.
Thank you.
If we stop
Yes.
Oh, desculpa.
No, pode falar.
No, I was going to say to Julie that you've got the